Good morning, everyone, and welcome to the latest episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is preparing for the end of the COVID-19 public health emergency on May 11th. Please note, this webinar is scheduled for 1 hour and 15 minutes. Thanks to everyone who submitted questions when they registered, as they helped us develop the content for this webinar. You may submit questions during the webinar by typing a message into the questions pane of the control panel. Also, immediately following the end of the webinar, you'll be asked to complete a short survey and submit any questions. We will respond to questions posed during or after the webinar via email. We have posted in the handouts pane of the control panel a PDF copy of the slides for your reference. Also, you will receive an email later today with a copy of the slides and a recording of the webinar. With that, I would like to introduce our presenters, Martie Ross and Kathy Reep.
Thank you, Trevor. Good morning. For those of you who have previously attended PYA's Healthcare Regulatory Roundup webinars, welcome back. And for those of you who are joining us for the first time, welcome aboard. We do this every other Wednesday, more or less, discussing the latest legislation and regulations impacting providers, and not surprisingly, we rarely cannot come up with something to talk about. In fact, we previously addressed the end of the public health emergency last September after CMS had published its roadmap for the eventual end of the public health emergency. But on January 30th, that eventuality became a reality when 1 day shy of the third anniversary of the original declaration of the public health emergency, HHS announced the PHE would end on May 11th. So after 1,195 days, May 11 will officially be known as the return to normal day. And while certainly we would prefer to be celebrating National Eat What You Want Day, or recognizing the true heroes.
Celebrating National Eat What You Want Day.
Most likely, yeah. Or recognizing the true heroes of the pandemic in National Nurses Week, we will instead be focusing now on how providers will be impacted by the end of the public health emergency.
I do wonder how Hostess Cupcakes got in there on the same day as Eat What You Want, but no comment.
You slid that one in, Reep. It wasn't me. I was National Eat What You Want Day. Anyway, first a disclaimer. The content that we will share this morning is current as of 11 a.m. Eastern Standard Time on March 1st. CMS has been very busy publishing additional guidance since it announced the end of the PHE back on January 30. In fact, on Monday, you received this email, if you're on one of those CMS email lists, announcing a new publication called What Do I Need to Know? A new 7-page fact sheet from CMS, which addressed some, but not all, of the implications of the end of the PHE. In that announcement, you note there with the red arrow, CMS promised that in coming weeks, it will hold stakeholder calls and office hours to address issues relating to the end of the PHE. And in fact, this afternoon, in a regularly scheduled open door forum for physicians, CMS has included in the agenda the end of the PHE. That's 2 p.m. Eastern Standard Time today. The other agenda topic is the No Surprises Act. So you can't get away from either of these topics at any given point in time. Our agenda today, and the reason we need an hour and 15 minutes with you as opposed to our usual hour, is pretty jam-packed. We're going to spend some significant time talking about the telehealth changes because it is not as simple as everything is extended to December 31st, 2024, unfortunately. We'll talk about the impact specifically on the use of telehealth for controlled substances with the publication today in the Federal Register of the DEA, Drug Enforcement Administration's proposed rule regarding the use of telehealth for such purposes. We'll talk about COVID-19 related reimbursement and how it's going to change, both for Medicare, Medicaid, and commercial payers. We'll talk about the Medicaid redetermination process, which is now officially in gear, right? I think this process is starting here. And then finally, we're going to wrap up with regulatory waivers and flexibilities, which we've learned is too big for just one webinar. That's a preview of what's yet to come. So let's start in on telehealth and virtual services. And of course, As you know, I want to do, we'll start with a history lesson because you have to know where you've been to know where you're going. And this story starts over 20 years ago with the addition of Section 1834M to the Social Security Act, which created coverage under the Medicare physician fee schedule for services delivered via telehealth. The restrictions Congress imposed on such coverage were significant. They restricted the geography, the location, the types of providers, the types of services, and the types of technology that could be used in delivering telehealth services. Most specifically, the geography restriction requiring that an individual be located in a rural area, the recipient of the services, and the location restriction, which required that that individual actually be physically present at a facility, not in their home, at the time the services were delivered. With restrictions like that, it is not surprising that telehealth was a little percentage of overall Medicare reimbursement under the fee schedule. And we saw a very limited adoption at any scale of those services. But then on March 6th, 2020, Congress passed the Coronavirus Preparedness and Response Supplemental Appropriations Act, which was the first of the big three pieces of legislation early on in the pandemic. And in that legislation, Congress granted to the Secretary the authority to waive the geographic and location restrictions during the public health emergency. Subsequent legislation, including the Families First Coronavirus Relief Package, which passed on March 18th, 2020, and then the big old CARES Act, which was the source of the Provider Relief Fund, if you remember that. That legislation passed on March 27th of 2020. Those further extended the Secretary's authority with regard to the expansion of telehealth services for Medicare beneficiaries. It's amazing how much Congress got done in March of 2020. I always say that March was the longest month ever that must have had at least 38 days in it, if you remember back to March of 2020. In fact, then on March 17th, CMS stepped in and said, ooh, let's flex some of this authority we have, and they announced the first of the telehealth related waivers, again, specifically focused on that geographic and location restriction. Then throughout the year, CMS continued to publish interim final rules that impacted the scope of the telehealth benefit, specifically with regard to the expansion of the types of services that could be delivered via telehealth and the types of providers who could deliver telehealth services. So fast forward now to the end of 2020, December of 2020, when Congress passed the Consolidated Appropriations Act of 2021. That legislation was important because it permanently removed the geographic and location restrictions for telehealth services for mental health conditions, language from the statute. And so now we know in the future, forever and ever, well, at least until Congress steps in again, that we will not have the geographic and location restrictions with regard to telehealth services furnished for mental health services. We did know that the restriction Congress placed on those services at the time is that there had to be a face-to-face visit at least within the 6 months prior to the initiation of telehealth services going forward, and then a face-to-face visit every 12 months, unless the parties determined that was not appropriate in particular circumstances. So that gets us through the end of 2020. Then in March of 2022, we get this Consolidated Appropriations Act of 2022. So at this point, we're looking at the pandemic, the public health emergency having lasted 2 years. Congress is looking forward, saying what happens after the end of the PHE. And this is where we extended the telehealth flexibilities for 151 days post-PHE, roughly 5 months following the, at that point, unknown end of the PHE. We would continue with the flexibilities that were afforded by legislation. And then through the rulemaking process in 2022, in the Medicare physician fee schedule final rule published in November of last year, CMS squared up the rules to the Consolidated Appropriations Act, ensuring the continuation of certain payment provisions. Certain services would continue through the end of the PHE, 151 days post-PHE. So that's where things stood in December of 2022. At that point, Congress passed the Consolidated Appropriations Act 2023. They have lost all creativity in naming these monster pieces of legislation, and now they are just all CAA insert year here. So CAA 23 extended the Medicare telehealth flexibilities through the end of 2024. Specifically, the legislative authority includes the continuation of the waiver of the geographic and location requirements. It continues reimbursement for physical therapists, occupational therapists, speech language pathologists, and audiologists for certain telehealth services. It continues the reimbursement for audio-only services, but only for those specifically identified, the audio-only E&M codes, as well as specified behavioral health and education services. All other telehealth services furnished to a Medicare beneficiary must be audio-visual to be covered. They delayed the effective date of the in-person requirement for telebehavioral health services. Again, remember in CAA 22, when we permanently eliminated geographic and location restrictions, we imposed that 6-month face-to-face requirement. So this legislation delayed the effective date of the 6-month requirement through now after December of 2024. The legislation continued reimbursement for federally qualified health centers and rural health clinics for medical telehealth services under that G code 2025, which currently reimburses at $98.27. Again, the CAA 2022 permanently extended FQHC's and RHC's ability to bill for behavioral health telehealth services. Okay. And then finally, the legislation continued the use of telehealth for purposes of recertifying eligibility for hospice and required face-to-face encounters for home health. And this is interesting here. This is not an extension of telehealth coverage under the Medicare physician fee schedule. This was instead a continuation of legislative authority to utilize telehealth in place of what is otherwise required to be a face-to-face visit as a condition of reimbursement under other payment models. We'll come back to that soon. So that's where things stand today with passage of CAA 23. We still need CMS to come in and address a few outstanding issues, just like they did in following the passage of CAA 22 through the rulemaking process. They resolved those issues going forward. We'll need them to step in to address a few other issues, beginning with the expanded list of telehealth services. What CMS did through its rulemaking process was create 2 categories of expanded codes. So we have what are referred to as Category 1 and Category 2 telehealth codes. Those are permanently included on the list of services that are available for reimbursement when furnished via telehealth. Category 3 were the codes that CMS said, let's stay with it a little longer. And rather than immediately turn those codes off at the end of PHE, let's extend them so we can further develop the evidence base for telehealth for these types of services. So currently what's been listed as a Category 3 code will continue to be covered through the end of 2023. What were non-Category 3 codes will presently be covered 151 days post-PHE. What CMS posted last week on its website was the statement that they anticipate addressing the telehealth services lists for CY 2024 as part of the established processes for the fee schedule. So what we expect is rulemaking now beginning this summer that will determine the treatment of these Category 3 codes. The problem here is there's a gap because these non-Category 3 codes, which will extend 5 months past May 11th, so roughly into October, will they effectively fall off the list, or will they be resurrected? And there's some pretty important codes that fall into those non-Category 3 codes about which we remain curious.
Because that physician final, we won't even have a physician final rule until November.
Right, and it doesn't take effect till January 1st. So
right.
We got a gap right there, which hopefully the agency will address. They have proven their competency in publishing interim final rules, so hopefully it will be addressed through that. Then we have the issue of payment parity. One accommodation CMS made during the PHE was increasing the amount paid to a physician practice for telehealth services. So pre-PHE, if you billed telehealth services from a physician practice, you were paid at the facility rate because the CMS's assumption was you don't have the same practice expense associated with delivering a service via telehealth. So we're not going to pay you that higher non-facility rate, which is intended to cover practice expense as well as professional services. But through the PHE said, hey, we want to encourage providers to do telehealth, so we're going to pay physician practices at the higher non-facility rate. Now, if you're a physician practicing in a hospital outpatient department, you are still going to be reimbursed the facility rate. This only truly benefited those who were practicing in the independent physician practice, so they would be reimbursed at that higher non-facility rate. Again, presently, CMS intends to continue that payment parity so that, in fact, the physician practice is being paid the same regardless if the service is delivered face-to-face or via telehealth. Right now, that's intended to continue through December 31st of 2023. CMS says that we still believe that the practice expense is lower for telehealth services. Yeah, right. But we'll see if they'll revisit this issue and continue payment parity through the end of 2024.
Martie, on the payment parity issue, we had talked previously that the Medicare Payment Advisory Commission has a report that is due in June on telehealth. It will be in their annual June report to Congress. But interesting discussion when they were reviewing the what are we going to do, what should we focus on? When they started talking about the facility versus non-facility rate, they were all pretty much in agreement, non-facility rate. But they raised another issue, and that was for telemedicine provided in by a the term they used, a non-bricks and mortar practitioner. In other words, a bank of
Right.
Okay, as opposed to a physician in his office or in a hospital setting. Okay.
So we're going to get a new place of service virtual?
And that what was very interesting because they are actually looking at that. Now, I don't know if it will ultimately be in their report in June, but there was a good deal of discussion in the MedPAC related to bricks and mortar docs as opposed to virtual docs.
Interesting. Well, that's why Kathy listens into MedPAC meetings.
Well, and
so
the issue that will be, the thing that will be interesting there is what it does to some of those organizations that have come into play, providing great time.
Very interesting. How that will impact providers that are doing it just as part of their normal practice as well. Right. Then how they'll set up as competitors. Interesting. Never a dull moment. The other big issue, similar, it's sort of in the same range as this payment parity issue, is the use of telehealth to provide direct supervision. So for incident to services when direct supervision is required, or for certain diagnostic tests when direct supervision is required. Think of all the circumstances where reimbursement is dependent upon that service having been directly supervised by the billing practitioner. Again, the accommodation made for the PHE was that direct supervision could be accomplished via telehealth, an audiovisual connection, i.e. the iPhone, correct? And CMS said, okay, we're going to continue that. We don't like it, but we're going to continue it through the end of 2023. But we have some reservations here about the effectiveness of this. So now the question becomes, if we're going to continue, again, if Congress has decided we're going to continue these telehealth flexibilities through the end of 2024, will CMS agree that that particular flexibility, which has been so critically important, will also continue through 2024, or will they finally decide that this is an appropriate way to deliver direct supervision going forward? The other one that keeps me up at night is what's going to happen with the Office of Civil Rights and the Office of Inspector General's notices of enforcement discretion. These were also published back on March 17th. I can remember distinctly reading these back on March 17, 2020, going, really? They're really going to do this? But it was extraordinary times with extraordinary remedies. OCR, Office of Civil Rights, is the agency that's responsible for the enforcement of the HIPAA privacy and security rules. Their notice of enforcement discretion said, we're not going to get into this issue of whether Zoom and Teams and these other platforms are HIPAA compliant, because we appreciate that that could potentially become a significant obstacle to these telehealth services being delivered during the pandemic when we were so worried about face-to-face communication. So they have stepped back and said, we're not going to impose any type of enforcement activity relating to the privacy and security of the modality utilized, so long as it's not a public modality. Office of Inspector General comes in and said, me too. They agreed with what the OCR had done, but the OIG also issued a separate notice of enforcement discretion saying we won't pursue any enforcement activity under the Civil Money Penalties Act for any provider that elects to waive copays or deductibles for Medicare beneficiaries for telehealth services. And they subsequently came back a week later and said, and virtual services, so chronic care management, remote patient monitoring. We've enjoyed that enforcement discretion and not required those copays and deductibles for those services. Again, will these agencies, and there's no word yet, check the websites right before we got online for the webinar, no word yet on what they intend to do with their enforcement discretion. Related to this, sort of an aside, because we're talking about OIG enforcement discretion, OIG also established a process during the PHE whereby providers could pose questions regarding whether certain arrangements between providers for the sake of the COVID-19 pandemic would violate the fraud and abuse laws. And over the course of two and a half years, OIG has posted 19 of these questions from the field, specific scenarios where they've said yes or no as to whether those would violate fraud and abuse laws. It's sort of a question now at the end of the PHE, those arrangements automatically then become potentially problematic. So for those of you that have relied on any of those clarifications, FAQs, whatever you want to call them, that came out of OIG, in any of your arrangements you've made with referral sources, it's probably worth a gander to see what's going to happen with that post-PHE. But back to telehealth. Sorry for that little diversion there. There are other telehealth flexibilities that end May 11th. And these, again, we're distinguishing here between telehealth as a reimbursable service under the Medicare physician fee schedule versus the use of telehealth in delivering a service that is otherwise reimbursable under a different modality. So beginning with, for example, subsequent inpatient visits. You've been permitted to use telehealth to perform those visits. Again, because we want to minimize face-to-face contact, we will go back to the old rule, which you can only use telehealth services once every 3 days. So other inpatient visits will need to be performed face-to-face beginning May 11th. For subsequent skilled nursing facility visits, you will be able to use telehealth only once every 14 days, again, reversion to the old rule. Critical care consults, its use of telehealth limited to once per day. For home dialysis, we go back to the rule that all required face-to-face visits must be performed, in fact, face-to-face, so no more use of telehealth for home dialysis. More broadly, there was a rule that if there was any national coverage determination or local coverage determination that required a face-to-face visit for some sort of evaluation or assessment of a patient, again, we had the accommodation during the PHE, those could be performed via telehealth. All of those go back to being face-to-face visits. For opioid treatment programs, they can no longer furnish periodic assessments by telephone. Instead, now they must use two-way audio-visual connectivity to perform those periodic assessments if they are not performed face-to-face. With regard to teaching physicians, only those teaching physicians who are located outside of a metropolitan statistical area at residency training sites can use telehealth to meet the key portion requirements. That had been a more broadly applied rule during the PHE that allowed that key portion to be done via telehealth. That will go back to only being permitted in non-MSA areas. Of course, that has never been permitted with regard to complex procedures or endoscopy or anesthesia services. And finally, hospitals and critical access hospitals must comply with the conditions of participation with regard to the provision of telehealth services to patients under contract with either a distance site hospital or distance site telemedicine entity. So those old credentialing rules that were utilized for telehealth providers had been relaxed during the PHE. They go back to full force and effect as of May 1. So all that credentialing of telehealth providers needs to be back in perfect order by May 11. So again, it's a lot more than just will you be able to deliver telehealth in a patient's home and have that be a reimbursable service. That in fact, through the PHE, the use of telehealth became much more ingrained in how we deliver a lot of services. And so again, this is a rollback, and these will take effect May 11th. These were not extended by the Consolidated Appropriations Act of 23. They have not been extended by CMS and any of their enforcement discretion up to this point in time.
From a compliance perspective, you need to figure out what you're doing and determine whether or not you need to be looking at enrollment, other things like that, in order to move forward, because May 11th will be here.
Yeah, and we're going to come back to this theme again and again. It's likely that the written procedure never changed during COVID. It's the actual practice changed.
Exactly.
It's not going to be a question of simply the compliance officer checking the policy and procedure. It's drilling down to how are we actually doing it, and does it match the pre-pandemic policy and procedure?
And as we've mentioned in the past, we've got staff who are doing things who were not there pre-pandemic and
They don't know what
were done.
They don't know what normal means, right?
Right.
Back to normal day means back to something different day for them. Briefly on virtual services, and remember CMS has made this hard distinction between telehealth services, which are a substitute for face-to-face services and thus governed by 1834M, versus virtual services where the very nature of the service is the fact that it's not delivered face-to-face, that there is some communication technology that's utilized. The accommodation CMS made here was to eliminate the established patient requirement for certain virtual services. That includes remote evaluation of patient-submitted video and images, virtual check-ins, and then remote patient monitoring. So those of you that have built up these fabulous remote patient monitoring programs during the PHE, and you have done that for new patients, we go back to the established patient rule, which has been applied again across these virtual services like chronic care management, like principal care management. And then when CMS introduced reimbursement for remote patient monitoring, it continued this established patient requirement. Now we can make a whole lot of arguments about why that requirement is problematic, but as of May 1st, as you're adding new patients to these programs, appreciate you're going to have to be able to check the box on meeting the established patient requirement. Also, with regard to remote patient monitoring, as of May 11, we're going to go back to the rule that you have to have at least 16 days of patient data to bill for the service, even if that patient has a confirmed or suspected case of COVID-19. The accommodation during the PHE had limited the data requirement to 2 days for patients with confirmed or suspected or confirmed cases of COVID-19. It all goes back to 16 days going forward. We're not done with telehealth yet. I told you it was going to take a while to get through this. Because now let's talk about telehealth services that are billed under the Medicare outpatient prospective payment systems. This is when hospitals get paid for telehealth services furnished in their HOPDs. So during the PHE, hospitals have been able to bill that telehealth originating facility site fee, which currently in 2023 reimburses at about $28.50. They've been able to bill that originating site fee as a hospital service for telehealth services furnished by a physician or a practitioner that's practicing in a hospital outpatient department, POS 19 or 22, to a beneficiary in their home. And the way we did that was CMS considered the beneficiary's home to be part of the hospital outpatient department. So that's been a significant, because we only reimburse the HOPD physician at the facility rate for telehealth services, this originating site fee that the hospital's been able to bill has been making up for that difference. So the question became, will that end with the PHE? Well, we no longer, because we'll no longer treat the beneficiary's home as an HOPD, we no longer can consider there to be an originating site. In the February 1 version of the CMS fact sheet for hospitals and critical access hospitals, we had this statement. We had the explanation of the rule, probably better explained than I just afforded you, but we had the explanation of this rule about originating site billing. And the language after it says, quote, after the PHE ends, this flexibility to bill telehealth services provided in the patient home as if it was provided at the hospital will end. That's the February 1 version. Thank goodness I printed it out, because last week when CMS re-released those fact sheets, the February 23rd version does not include that sentence. So does that mean that hospitals are going to be able to continue billing the originating site fee after May 11th? It appears so, because there is nothing in that fact sheet that explicitly says it's discontinued. So hope CMS clarifies that, but this is why you have to read your fact sheets really carefully, because you will, if you remember this from the Provider Relief Fund, you know, we had to read those FAQs every time they republished them to see what they had changed. And this is yet another example in these provider fact sheets. This change in language can have a significant impact on the reimbursement a hospital is receiving for its telehealth services. Let's talk about hospital-only remote outpatient therapy and education services. Okay, so during the PHE, hospitals could be paid under OPPS for a subset of therapy and education services, and that included partial hospitalization services for those who were for services that were delivered remotely by hospital clinical staff to beneficiaries which were in their home, again, because the home qualified as an HOPD for purposes of the pandemic. This is services that the hospital clinical staff themselves did not separately bill for those services under the Medicare physician fee schedule, either because they didn't have the appropriate qualification or for some other reason. They were qualified under state law to deliver the service, but there wasn't a vehicle for separate reimbursement for their services. So these services were treated as hospital outpatient department and reimbursable under OPPS. So after May 11, it is clear still in the fact sheet that this payment will no longer be available, again, because the beneficiary home no longer qualifies as an HOPD. However, in last year's OPPS final rule, CMS sort of bridged the gap by creating new reimbursement for mental health services furnished by hospital clinical staff to patients in their home. And they said that we'll provide payment under OPPS for those type services, those mental health services, but only if the patient had been seen in person 6 months prior to the initiation of services, and that there was a face-to-face visit every 12 months thereafter with exceptions. That's very similar, obviously, to the language that's in the CAA 2022 that created that exception to the geographic and location restrictions for mental health services. So we're effectively mimicking what's going on with the Medicare physician fee schedule for mental health services now in OPPS. However, in the final rule, CMS made clear that these types of remote services are not recognized nor reimbursed as partial hospitalization services. Those will still, after May 11th, those will have to be face-to-face services, although these services are available to partial hospitalization patients. Also, CMS clarified that we will permit these services to be delivered audio only by hospital staff to the patients in their homes. So that's where we stand on those services as of May 11th. Believe it or not, one more topic and we're done with telehealth. And that's the issue of what about everybody else? Medicaid and commercial telehealth coverage. as they say, if you've seen one Medicaid program, you've seen one Medicaid program. They vary from state to state as to their coverage for telehealth services. The best resource I have identified is the Center for Connected Health Policy. You see the website there. They maintain an inventory for each state as to the current status of Medicaid reimbursement for telehealth services, and they send you to the original state documents so that you can review them. They also talk about state telehealth coverage and payment parity laws. Again, for commercial payers, this issue of whether they provide coverage for telehealth services is determined in part by whether the state in which that insurance is offered has a parity law. And there are two types of parity law. There's the parity law that says if a service is can be delivered via telehealth safely and effectively, you have to cover it just as you would a face-to-face service. That's just coverage. The next step is payment parity, is that not only do you have to cover it, you have to pay it at the same rate as a face-to-face service. There's a smaller number of states that have gone to the point of having payment parity laws. So those will be important. Be sure you appreciate for any commercial plan for which you're providing telehealth services that you have in fact confirmed that that coverage will continue after the pandemic. Aware in some states already, large insurers are saying that yes, we'll continue to provide coverage, but because there's no payment parity law in the state, they're already announcing they're going to reduce payment for telehealth services by 20 or 25%. So just be aware of what's going on in your state. Finally, the tax law. Who thought this would come into play when we talk about telehealth, but it does. There have been certain federal telehealth flexibilities for commercial health insurance with regard to coverage and treatment of telehealth services. We will continue to allow telehealth coverage pre-deductible for catastrophic plans for plan years that began prior to January 1st of 2024, as well as HSA qualified health, high deductible health plans. Again, we'll have coverage for telehealth first dollar for plan years beginning prior to January 1st of 2025. So there you go. That is telehealth. Let's shift gears, talk about controlled substances. And actually, we're still talking about telehealth because we're talking about the prescribing of controlled substances based on a telehealth visit. This is not, now we're switching gears. We're no longer with CMS. We're no longer with HHS. We're now over in the Department of Justice, where the Drug Enforcement Administration lives. And these are the rules they have developed under applicable legislation with regard to the use of telehealth for prescribing controlled substances. Let's start with opioid treatment programs. And actually, we're still in HHS because this is regulated by SAMHSA, which is a HHS agency, and it's access to for OUD treatment in an outpatient treatment, an opioid treatment program. There is a December 2022 proposed rule from SAMHSA that would make permanent the PHE flexibility to initiate treatment via telephone, effectively no in-person physical exam requirement. That same proposed rule permits the initiation of methadone therapy via an audio-visual examination. They distinguish between the side effects associated with the two drugs, why it's important to have a visual exam as in addition to just the audio communication. SAMHSA is committed to providing an interim solution if these rules are not finalized by May 11th. That they've also, another rule, expanded methadone take-home dosage. SAMHSA has previously, during the PHE, afforded flexibilities for 1 year post-PHE. So again, if a person's in a methadone clinic, how many doses can they take home with them? SAMHSA says we'll continue the rule that's been in place for a year following the end of PHE, so through May 11th, 2024. Again, that December 22 proposed rule would make those flexibilities permanently. Also, just of note, our friend, the Consolidated Appropriations Act of 2023, eliminated data waiver requirements to prescribe medications for opioid use disorder treatment for all practitioners. And so no longer just opioid treatment programs can prescribe these drugs. You now will waive those requirements for all practitioners. So that certainly, hopefully, will improve access to those medications going forward. Then we get to the issue of prescribing controlled substances act. So yeah, now we're with the DEA. Sorry for that little SAMHSA sideline there. And this is where we get to the Ryan Haight Online Pharmacy Consumer Protection Act. That law requires that a practitioner conduct at least one in-person medical evaluation prior to prescribing any controlled substance. The concern here was that these telehealth providers were very freely writing scripts for controlled substances, which created, the opportunity for misuse and abuse. Once you have that one-time in-person visit, that practitioner then can prescribe via telehealth going forward. There's no follow-up in-person requirement. There's no time between evaluation and prescribing. You just have to have that one time you laid eyes on them physically, face-to-face. There were exceptions built into the statute. So if you were a covering practitioner, so if Dr. Ross had seen the patient and was prescribing via telehealth, and I was unavailable, then Dr. Reep, as my covering practitioner, would be able to prescribe via telehealth. There was an exception for public health emergencies, and that's what the DEA relied on when it permitted telehealth prescribing without an in-person evaluation through the end of the PHE. And then there's this other exception in the statute called the registered telemedicine provider, that Congress envisioned the DEA would create a system where a provider could demonstrate that they behaved appropriately, followed the rules, and they would become a registered telemedicine provider, permitted to prescribe without that required in-person visit. Despite Congress saying, please DEA, do this, DEA has not done this. There's been a proposed rule that's been sitting over in the Office of Management and Budget for about a year now, but they still have not moved forward with it. Instead, on Friday, DEA released its proposed rule on how it intends to create a vehicle by which prescribers can continue to prescribe controlled substances based on a telehealth visit only without an in-person examination. The rule was formally published in the Federal Register today, and it has a whopping 30-day comment period. So they say we're only allowing 30 days because we want to get this rule finalized as close to the end of the PHE as we can, because we know that under the statute, our authority to waive ends with the end of the PHE. So we're creating this regulatory process under what we believe our authority is under the Ryan Haight Act. And you see here, this is not my work, this is DEA's work, summarizing how this rule would work. The big hit here is no Schedule II drugs will be able to be prescribed via telehealth without an in-person visit. So Adderall, Ritalin, Oxycontin, those Schedule II drugs are still going to, would as of May 12th, require a previous face-to-face visit before they could be prescribed via telehealth. For the rest of the scheduled drugs, 3, 4, and 5, you would be allowed to do a one-time 30-day prescription. And thereafter, you could only renew that prescription had there been a face-to-face visit, or prescribe the drug again only if there had been a face-to-face visit. There are all sorts of registration requirements associated in this proposed rule. There are all sorts of information has to be noted on the prescription itself. There's going to be rules that pharmacies will have to follow when they bill these rules. It's just, there are lots of opportunities to comment, as Kathy would say. And please take a look at this rule if this is impacting you directly. We're encouraging folks to get in there and comment, because given the tight time frame, it looks like DEA has kind of made up its mind, and it's going to be very important that they hear from industry about the potential issues. You see down there more information from DEA, the link to more information from DEA regarding this proposed rule. And again, it's published today in the Federal Register.
And before you go on, Marty, one thing on this, if they actually want to have a final rule out by May 11th, and you think about the normal process for responding to comments and going through OMB for final review, et cetera, the earlier you get your comments in, the more likely they're going to be considered, because they're going to be up against a time clock to get something published before May 11th.
Yeah. And FYI, when you go on the Federal Register site, there's during the comment period while it's open, there's a link and you can access all the comments that have been filed to that point. The link goes away once the comment period's open, but you can certainly get some input on what other providers are saying, because this is one, if this impacts you, one we're going to need to weigh in on and try and impact what DEA is doing on this. And they interestingly, in the proposed rule, they once again said, yeah, we really don't like this idea of registered telemedicine providers. We just don't want to do that, even though Congress has now told them twice to do it. Far from me to criticize a federal agency, right, Kathy?
Right.
Okay.
Absolutely.
Over to you. Show me the money, Kathy. Show me the money.
Okay, it's always about the money. So let's talk a little bit about vaccines, testing, and treatment, Medicare, Medicaid, and commercial. We're just going to kind of go through each of those in terms of what the end of the PHE means for reimbursement from the various payers and for various services. So first of all, let's take a look at the vaccines. Medicare has announced that they will continue to cover the COVID vaccines without cost sharing, similar to what they've done for flu in the past. So the payment amount will vary from year to year, but essentially we're starting out at the $40 per dose amount. State Medicaid plans, again, will continue without cost sharing through the end of the federal fiscal year through 9/30/24. But then coverage is going to vary from one state to the next. You're going to need to know what your state is going to allow for Medicaid vaccine coverage of Medicaid vaccines. And then last but not least, we'd take a look at the commercial payers, and they are going to continue to cover without cost sharing. Don't know for how long, but at least for now, no cost sharing for the COVID-19 vaccines. If you're uninsured or underinsured, obviously you're going to be hit with the payment for the bill and that you would be paying for your vaccines out of pocket. Because we got a question on this, Marty, the issue related to the vaccine mandate, emergency temporary standard for occupational exposure, no changes there.
Nope, neither of those regulations were linked to the PHE. They are separate standing. In the case of the vaccine mandate, it's part of the conditions of participation. The OSHA ETS remains in place, although if you go to OSHA's website now, it says coming soon, new guidance. So we'll see what moves forward on that. As it stands today, what you're doing to meet OSHA requirements remains in place regardless of what happens, at least until they change their mind, but May 11 has no impact.
But the other thing, just with the DEA, we saw a rule come out where they are speeding things up, trying to get done before May 11th. We have no idea if we could see something from OSHA coming out similarly.
Yeah, ETS was an interim final rule, so maybe that's the route they go. But yeah, hopefully something happens.
Published without comment.
Yep.
On to the next slide, let's take a look at testing. Again, Medicare, Medicaid, commercial. So Medicare will continue to pay or cover COVID testing without cost sharing, but there are certain provisions that will end at the end of the PHE. I'm not going to go through each one of these, but I think the one that I need to stress for providers is the higher payment rate for COVID tests that use high throughput technologies. That the higher payment rate will go away. The issue of Medicare coverage for the beneficiary having a first test without a physician or practitioner order, that again is going to end with the end of the PHE. And the rule that permits providers to bill 99211 for staff assessing the patient and collecting the specimen for the COVID test, that too will end. So recognize that your billing process is going to change under Medicare. Although they are still going to cover without cost sharing, there are certain restrictions in terms of exactly what they will cover. Medicare Advantage will continue to cover Medicare COVID-19 testing, but they will, the cost sharing will vary with the individual product that the patient has enrolled in. Medicaid, again, just like with the vaccine, they will cover without cost sharing through the end of the federal fiscal year in 24, but then coverage varies by state. Commercial plans, again, no mandate on them, and therefore their coverage will vary. The requirement for you to actually have out on your website the information related to what you charge your cash price for COVID-19 tests. I know the slide says it will terminate. That is the clear and distinct. This is what we charge for COVID, but recognize you still have your price transparency requirement to have posted all of your charges. So this is going to be a lab test that will be out there within your charge master posting for the price transparency.
Yeah,
And then,
Kathy, I mean, that rule applies to hospitals. It's the physician practices, the clinical labs. All
that's true. That's true. Would go away. Yes. And then last but not least, let's take a look at treatment because again, from the Medicare, Medicaid, and commercial perspective, we know that the 20% add-on payment for the DRG related to those patients with a COVID diagnosis, that will end on May 11th. But what does that mean? We don't have any clarity yet, because what about the patient who is admitted and discharged after May 11th? Or are we looking at admissions occurring on or after? This is clarification that we're going to need from CMS. Martie mentioned that the physician open door call this afternoon is going to have as an agenda item the end of the PHE. Tomorrow's call for skilled nursing will address end of the PHE. I have a feeling we're going to have a hospital open door call very quickly. There was one, I guess, earlier this month, but this was, they really didn't get into the PHE. I think we're going to see something coming very quickly. That separate payment for drugs and biologics that were approved to treat COVID-19, that separate payment is going to end, and the cost for those services will actually be bundled into the composite APC when it's billed on that same outpatient claim. The Medicaid programs, again, the same line. They will continue to cover treatment without cost sharing through September 30th of 24, and then it will vary by state. And last but not least, the end of the PHE will not impact what the private health insurance plans are doing. Their coverage will continue as it is now. And Martie, the impact on the FDA emergency use authorizations.
Again, another question we got through registration, none. Again, all the FDA emergency use authorizations for all different COVID treatments, they are not tied in any way to the PHE. The usual process will continue for FDA to approve those drugs permanently.
Okay, thank you. Jumping on to the next topic, but still, let's talk money, the Medicaid redeterminations. So I think we're all aware that beginning, well, the end of this month, the continuous coverage requirement for continuous coverage in Medicaid under the PHE, it will end on March 31st, pre-end of the PHE. We are now going to also begin to see, or we are now seeing, a phase down in the enhanced federal match that states received for their Medicaid programs. There was an increase in the federal match up to 6.2% increase in the federal match. And we're seeing that as of April 1, that match is going to go down to 5%. And it's going to continue to drop to the end of the year. Last 3 months of the year, it'll be 1.5%. And then beginning in January of 2024, we will be back at our regular match for the Medicaid programs. Under this continuous enrollment requirement, states are now going to be required to do a redetermination on all Medicaid enrollees. There have been no redeterminations for the last several years. So now they have to move forward with doing a redetermination on all Medicaid enrollees to determine whether or not they actually continue to meet the requirements to be in Medicaid. If not, they will be disenrolled. There will be a requirement for states to do monthly reporting in terms of their redetermination process, where they are in this. It has been projected that about 5 million people are likely to become uninsured through this renewal process. And then Martie, some very interesting information on the next slide, because remember, sometimes it's difficult to reach out to these Medicaid beneficiaries or enrollees to get additional information to continue their enrollment in the program. A study that was done by the Urban Institute and Robert Wood Johnson Foundation in December of last year found that 64.3% of the adults who were enrolled in Medicaid or with an enrolled spouse, partner, or child didn't know about the redetermination process. Not sure that there has been a lot of education of enrollees since December to educate them that this was coming. There is going to be work on the part of those enrollees in order for them to keep their enrollment in Medicaid, to keep their coverage. We really are not sure what's going to happen. Many of you represent hospitals and physicians' offices, and we encourage you that as you are dealing with patients who are currently covered under Medicaid, to make sure that you take a step to educate them about the fact that the state Medicaid programs will be reaching out to assess their continued eligibility for the program. Something that you really need to make sure that they are aware of and they don't ignore this outreach.
Yeah, there are all sorts of procedural protections that CMS has mandated on state Medicaid programs. But at the end of the day, if the beneficiary, they've made all the good faith effort required and they do not hear from the beneficiary, the redetermination is that person's no longer eligible because they have not demonstrated eligibility. So that's it's the baby with the bathwater issue, is that you're going to have plenty of folks who went on Medicaid during the pandemic because they met minimum income requirements and have since become employed, or their kids remained on Medicaid once they went back in employment and had commercial insurance. So there's plenty of those cases, but there's going to be plenty of folks who still qualify who do not respond to the redetermination information and end up going off Medicaid. And again, if you are a Medicaid provider, appreciate the significant impact this can have on your bottom line and your interest in making sure that these patients are responding.
And so I would encourage you to have a dialogue with your Medicaid patients as they're coming in to make sure that they are aware of the redetermination process and that they are responsive. Okay, waivers and flexibilities. Here we go. And this kind of becomes a little bit of a precursor to the next regulatory roundup that we'll be doing on March 15th. But I think that certain states have been very familiar with the 1135 waivers and the opportunity to address CMS to get waivers of certain requirements when there is a declared emergency. This is something we've done in the case of hurricanes, fires, tornadoes, etc. But we saw this massive number of 1135 waivers that were extended across the country because of the public health emergency. Under the rules that exist related to the 1135 waivers, essentially HHS has been able to waive a number of requirements during a public health emergency when we start looking at issues that impact beneficiary access to care. So these are going to be things like physical space, capacity, regulatory burden. I mean, doing this reporting is a burden, and when I'm dealing with these other things, well, the PHE is going away. So those flexibilities that we had that were established, just blanket waivers across the country, are also going to be going away. There are over 200 regulatory flexibilities that are in place that we're going to lose on May 11th. And when we say lose on May 11th, it's not a grace period like with telehealth. It's they are gone overnight. What you can do on May 11th or May 10th is different than what you can do on May 11th. So Martie, the fact sheets, the list of fact sheets on the next slide, we know that each of these fact sheets has been published by CMS repeatedly, but they do keep changing. And I would say as an example, yes. Our next webinar is going to be Martie reading the fact sheet. No. Please plan 2 weeks. No, here, seriously. But unfortunately, what we are seeing, just like with the initial, what do I need to report, or the short and dirty fact sheet that they published that was like 10 pages, all of these fact sheets are being reissued frequently. Particularly now as the PHE winds down, because they are clarifying things. As soon as people ask them questions, I guarantee you, following the physician open door call today, based upon questions that might be asked, there will be a revised fact sheet. And so you need to be aware of these. Currently, all the fact sheets are out and available. They were last updated February 23rd. But I guarantee you somebody's going to be addressing the question of, for the 20% add-on payment for the inpatients. What happens if a patient is admitted? That's going to be a revised fact sheet that's going to be coming out. So recognize that you do have to continue to be in touch with those and continue to look for changes, or listen to Marty and Kathy.
Well, to that note, Kathy, I'm going to go ahead and let the cat out of the bag. These provider fact sheets are not checklists, and in a frustrating way. They are not organized by specific topic. They are roughly, I mean, there's a section on reimbursement, there's a section on Stark, there's a section on enrollment, but they are not in an organized fashion as one would think a checklist was. So Kathy and I have committed to generating such a checklist. And that is the intent of the March 15th webinar, is to introduce you to that checklist, to go into it in greater detail. Matthew, our magician behind the scenes, our technician, is going to post the link to the website for the registration for that webinar, but it will also be posted on our website as well. And then, of course, we'll release the checklist publicly after the webinar as well, and intend to update it as are the fact sheets updated by CMS. But again, let's just at least get in our vicinity of what how broad these flexibilities are and how they really are going to be in nooks and crannies of your facilities. Let's start with the waivers regarding expansion of physical space. Okay, so we want more room to take care of patients. This was referred to generally as the Hospital Without Walls initiative. And this permitted hospitals to use other locations than designated inpatient beds to deliver inpatient services. So they were able to use non-patient care areas like, conference rooms. They could use distinct part units. So rather than the inpatient psych beds were then used for inpatient services, and they even were permitted to go so far as to use community facilities. And in fact, many of you were using hotels to provide coverage for the expansion. All of that ends May 11, and you have to go back to what were the designated inpatient beds at your facilities and where you can deliver inpatient services. There have been exceptions to EMTALA that permitted screenings to be performed outside the emergency department, which is a big no-no in the EMTALA world. But again, we will shut all that down, or assume that it will all be shut down by May 11, and go back to the EMTALA medical screening requirements being performed in the emergency department. There was the ability of hospitals to create new HOPDs or relocate existing HOPDs, again, to expand capacity. That included the adoption of temporary extraordinary circumstances, relocation exceptions for on-campus and accepted off-campus HOPDs, and also the ability to deem a patient home an HOPD for services furnished within the hospital staff. And here I'm talking about the physical delivery of services, right? So wound care or infusion being done by hospital staff in the patient's home, deeming the patient's home part of the off-campus part there. That discontinues, excuse me. Oh, sorry. There was a provision in the Hospital Without Walls that allowed PPS hospitals to use swing beds to provide SNF services. There was quite a process you had to go through to be designated for those purposes. If you still have those swing beds, they will be discontinued May 11. For critical access hospitals, given the surge capacity you were dealing with, CMS gave you a pass on bed count, so you were allowed to expand beyond 25 beds, as well as an effect of not enforcing the 96-hour rule. We know that those go back into effect May 11. How exactly CMS intends to calculate compliance with the 96-hour rule Since you're beginning in the middle of a year at the end of the PhD, I think that's going to be one of those open door questions that they need to answer. Some cause of established non-rural offsite clinics in non-rural areas. Those are going to have to be shut down or obviously change the reimbursement model for them. And finally, hospitals that have maintained their classification as sole community hospitals or Medicare dependent hospitals. Again, you've been excused from variations and fluctuations in your census from the calculation of those numbers. Again, back into effect on May 11. Again, how is that going to be calculated given that it's an average over a period of time? Again, more questions to be answered. Kathy?
Yeah, and before I even jump into hospital care at home, let me just mention, we keep talking about these open door calls. One thing that you can do for any of the open door calls is actually submit a question in advance. Sometimes it's difficult to get into the queue to ask a question live on a call, but you can submit a question in advance. We're going to be talking in a minute about skilled nursing, and there's a SNF call tomorrow. I'm going to go in right now, or actually when this webinar is over, and submit the question about when do we start counting. The next time we have either a rural call or a hospital call, we need to be submitting that question related to counting the 96 hours for critical access hospital. Let's get those questions submitted to CMS now, and it shouldn't just come from one person. It should come from a number of people so that they realize that this is an important issue that needs to be addressed. So back to hospital care at home. We do know that this was a program that was put into place through a waiver under the public health emergency that in many areas has had great success. Not only satisfaction on the part of the providers, but also the patients who are receiving acute hospital care at home. They are very happy not to be in a hospital. And we've got reports that address patients are doing better being at home. And we also have reports that actually indicate that costs are gone down. The cost of providing the care has gone down because fewer lab tests and things like that are ordered. It's just too easy when they're in the hospital. Currently, about 260 hospitals have acute hospital care at home programs. They need to recognize that under the Consolidated Appropriations Act of 23, their waivers have been extended through December of 24. This again is going to give that opportunity for CMS and others to evaluate the success of the program and to determine whether it continues beyond that. I would not doubt that in the 2023-24 work plan for MedPAC, I have a feeling they will be doing an assessment of acute hospital care at home.
Yeah, and again, remember this is open. This waiver is still open, and they're still adding hospitals
Right.
that have been approved for the waiver. So if you were on the fence, you've got a year and a half to stand up a program until this waiver is over. And yeah, I would bet if this doesn't continue as a waiver, then CMMI is going to pick it up as an alternative payment model. So I think this is here to stay in some form or another.
Yes. We mentioned this already, and it's the issue that you've heard me talk about several times on these webinars. Historically, there has been a requirement for a patient to be in a covered skilled nursing stay, that they were an inpatient in a hospital for 3 consecutive days or more prior to that inpatient admission. It doesn't have to be consecutive, but at least within the last 30 days that they were had an inpatient stay of 3 days, 3 consecutive days, and then were admitted to skilled nursing. At the end of the PHE on May 11th, that waiver is going to go away. So we get back into that same question that we had earlier about the add-on payment for the DRG, and that is, what if you are admitted to the SNF, did not have a 3-day prior stay, were admitted to the SNF prior to May 11th, discharged after, is your stay covered? When does the clock start? And so we do need to make sure that we get that question answered. But if we even go to the next slide, I keep raising this issue that CMS, every time they publish Their fact sheets by provider type. They keep changing the language related to the SNF stay. The original fact sheet that was published in May of 2020 said that the waiver applied to all SNF level beneficiaries, regardless of whether the care of the beneficiary requires or has a direct relationship to COVID-19. Beginning in May of 21, they started changing that to for those people who experience dislocations or otherwise affected by COVID-19. So because that language has changed, questionable what we've been, if we have not been keeping patients without COVID or who were not dislocated for that 3-day qualifying stay, that it could be a compliance issue going forward, but recognize no matter what you've done over the last 2 years, this is going away on May 11th.
Yeah, interestingly, this is not addressed in the hospital provider fact sheet. It's only in the skilled nursing provider fact sheet, which in fact, this probably most directly impacts discharge planners at hospitals, because this option to put a patient in post-acute care is going to be cut off. And unless they've been doing that job for more than 3 years, they've lived in a world where you could always send someone to a SNF.
Or they were reading the SNF guidance previously and saw that the language had changed. So be interesting.
So it will be interesting, definitely. Enhanced workforce capacity, very, very briefly. The other thing about the SNF waivers, if you are relying on a waiver under a Medicare shared savings program or ACO REACH or the like, those do not go away. Those stay in place. It's just those more general waiver that's in place. Workforce waivers, there have been an assortment of accommodations that CMS has made intending to kind of grow out the workforce. These are not as impactful, but again, these are going to be the nooks and cranny of your hospital, such as the medical staff requirements. And when you had to re-privilege physicians, those cops were relaxed. They go back up to full strength. So make sure the medical staff office is aware of those requirements. They're back in compliance with pre-2020 requirements. For critical access hospitals, the one to pay attention to here has been physician physical presence. The COG requires there be a physician physically present at the critical access hospital a sufficient amount of time to provide medical direction, consultation, and supervision. It's always been, well, how often is that? But how often that it is that has not been an issue since 2020 because CMS has permitted that level of supervision to be performed via telehealth. Again, that goes away. So if you're a CAW, it's once again time for a physician to be darkening your doorstep on a regular basis to meet that condition of participation. Switching gears finally, there are specific waivers here with regard to teaching hospitals and teaching physicians of when the time counts and when it doesn't count. So if you are hospital reliant on this reimbursement, be well aware of these changes to the rules so that you can count time appropriately.
And Martie, on that, the one thing I want to call out, and I know we're short on time, is that we have the waiver that has allowed the residents to provide care outside of the normal setting. That goes away, but more importantly, I think from a reimbursement perspective, since that's my thing, is that any added beds will be considered in determining your IME payments. Remember, for inpatient acute, the operating payment for indirect medical education, it is residents to available beds. If you have added beds, they are going to be looking at this and calculating your IME payment. Historically, well, not historically, during the period of the PHE, they have not looked at those additional beds in calculating IME. Now they will be.
Last but not least, so much so that we're going to do a whole nother webinar on it. Renewed regulatory burden, as I call it. These were all the exceptions to regulatory burden that CMS gave us a pass on for 3 years, and they're back. Everything from authentication of verbal orders within 48 hours. We've had a pass on that. It goes back to the 48-hour rule. The information provided to patients during the discharge planning process regarding their post-acute options, we've been excused of those requirements. Those are back. Same with regard to information on advanced directives. Those are back. To those of you that have relaxed certain provisions in your utilization review and QAPI programs, in terms of the scope of those programs, we are back to the full COP requirements as of May 11th. And you see here other requirements that will be going back into effect. One to call your attention to are the provider enrollment rules, and that if you've had physicians who are more than infrequently providing telehealth services from their home, we've had an exception that did not require you to list the home address on their provider enrollment forms. As of May 11, you do have to include their home address as a site of the location in which they're providing telehealth services if it's more than infrequently. So we'll need to be catch up and giving, updating those 855 forms accordingly. That was a lot. We saw some folks dropped off because we went beyond the time allowed. Beyond the 1 hour again. So we'll revisit this topic as we started putting the PowerPoint together. We knew it was more than just a one-time hit. So a deeper dive on sort of these waivers and flexibilities, trying to give you a useful checklist so you can find those nooks and crannies in your facilities that are going to be impacted by the end of the PHE. Kathy, I really think we should go for
Martie,
whatever you want day to day.
Because of the evaluation that will be coming, if there's certain provisions you want a deeper dive on, please put them in the comments.
Absolutely. And again, when we do registration, we'll be soliciting comments as well for that webinar. So thanks very much for joining us. Happy March 1st, and we'll hopefully talk to you in a couple weeks.
Take care.
Thanks to our presenters, Martie Ross and Kathy Reep. Later today, you will receive an email with their contact information and a recording of the webinar. Also, the slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series, all 44 of them, are available on the Insights page of PYA's website, www.pyapc.com. While at our website, you may register for the March 15th webinar and learn more about the full range of services offered by PYA. Please remember to stay on the line once the webinar disconnects to complete a short survey and post any questions you may have. On behalf of PYA, thank you for joining us and have a great rest of your day.